Welcome to IDWeek Presentation Theater. Is it bacterial or viral infection? Using host response technology to decode the immune system and aid antibiotic stewardship. Hi, I'm Debbie Goff, a professor of pharmacy practice and an infectious disease specialist at The Ohio State University Wexner Medical Center, and I'll be speaking today on this topic. Let's start with a case. Antibiotic overuse. We have a 50-year-old female who presents to the emergency department with a high fever. She was generally healthy, but her symptoms now are 5 days of fever up to 102, non-productive cough. On physical exam, she has decreased breath sounds bilaterally. Her lab values, she is COVID negative by PCR test. She has an elevated white blood cell count, CRP of 36. Blood cultures have been sent. Chest x-ray done in the ER shows a left lower lobe infiltrate. So our colleagues in the ED have a dilemma. Is this a bacterial or a viral infection? And they are a real important component to antibiotic stewardship because whatever they start in that ED, if the patient gets admitted, we have to deal with that. So if they start an antibiotic that we may or may not agree with, it's going to get continued probably in the inpatient setting. And so the challenge is, do you treat this patient or not? And why do we have this challenge? Because the diagnostic tools are not yet quite there to empower us to make this decision. I love this new study just published a couple months ago by the CDC. The likelihood of bacterial infection in patients treated with broad spectrum antibiotics in the emergency department, exactly what our patient case scenario is. And they found 35%, over a third of patients empirically treated with broad spectrum antibiotics in the emergency department are ultimately diagnosed with a non-infectious or a viral condition. Unnecessary antibiotics prescribed to 35% of patients because we can't make that distinction in the ED setting. So that's really where we need to improve the care of patients. So the challenge for antibiotic stewardship in addressing this, why do we give these antibiotics unnecessarily? It's fear of missing something. It's not a knowledge deficit. Physicians know what the guidelines state. And this paper that I'm referencing here by Rich Wunderink is a great paper by our critical care colleagues that really addressed stewardship in the ICU setting. This paper is co-authored by one of my colleagues, Anthony Gerlach, our surgical ICU pharmacist. It's a collaborative paper by critical care physicians, nurses, and pharmacists, the CDC, looking at why do we do what we do? Why are all these antibiotics prescribed and they end up being unnecessary? It's not because they can't follow guidelines. It's the fear of missing an infection. And because our diagnostic tools are not perfect yet, that fear remains and therefore antibiotics get prescribed. So the role of diagnostics and antimicrobial stewardship in the clinical setting are twofold. Antibiotic stewardship is about getting the right drug at the right dose at the right time and the right duration. But it really starts, step one is diagnostic stewardship. If you don't know what the diagnosis is, you can't really prescribe the right antibiotic. So you need the right test for the right patient at the right time. That's diagnostic stewardship, and that's why stewardship is done hand in hand with our microbiologist. So this is a new paper by microbiologist Donna Wolk, Diagnostic Stewardship Interventions That Make a Difference. If you're looking at implementing a new diagnostic test, it should support the Joint Commission requirements for both inpatient and outpatient stewardship. Can the test be used in both, or is it so complex or so expensive that the only role for it is in the hospital setting? Is the test actionable? Can it be acted upon in the inpatient and outpatient setting where it will drive therapy? Will the test actually reduce shorter times in the emergency department, wait times, and reduce unnecessary ED visits? Imagine if you had a test in the outpatient setting that could distinguish between bacterial or viral rapidly, that you could avoid sending the patient to the ED. So There's a lot of things we still need. We have a lot of new technology, but nothing is quite yet perfect. So the components that are essential to really deliver excellent care: diagnostic intelligence, meaning do you have the decision support and the risk stratification to do diagnostic stewardship? Is your microbiology lab running 24/7? Or are they short-staffed, or there just aren't enough microbiologists and it's only open during working hours? Diagnostic readiness, the subject matter expertise and value-based care. There's a lot of new tests, a great pneumonia panel, but the results are presented in copies per ml. Who's going to educate the physicians on what copies per ml means clinically? It's a new term, it's a new test. So stewardship has to be part of that diagnostic readiness. Does your hospital have that manpower? Diagnostic interventions, diagnostic speed and accessibility. I always say the rapid diagnostic test, if not acted upon rapidly, has little value. So you need that partnership. And then antibiotic stewardship and the financial stewardship. Every test is a new expense for the hospital or the outpatient setting. Do you have the ability to show your CEO, or if you own your own private practice and you're implementing this test, what's the return on investment? If I implement this test, does it really help my patients and provide cost-effective care? IDSA published this paper a while ago on molecular tests for acute respiratory tract infections, both the clinical and diagnostic recommendations from IDSA. And I like this little flow diagram that they put together: the technical efficacy and the diagnostic efficacy of the test, the diagnostic decision efficacy. Can you make decisions based on this test? Therapeutic efficacy, does it actually change the way we manage these patients and treat them because of this new test result? And most importantly, then, is the patient outcome efficacy. Does it change morbidity or mortality because we know the organism, or is it viral or bacterial and can target our therapy effectively from a very quick turnaround, maybe in an hour or day one versus 3 to 4 days with traditional culture methods? And then the societal efficacy, the cost benefit and cost effectiveness from a societal perspective. So that's ideally what we should be looking at as we evaluate therapy. And I think what's so exciting, as I've been working with diagnostic tools for many years now in my career, we have multiple diagnostic tools to support antimicrobial stewardship. We published one of the first studies in 2010 looking at a rapid diagnostic test with stewardship interventions. And now, the challenge today is, which tool are you going to use? Because there are so many different ones: multiplex PCR pathogen detection, rapid culture pathogen detection, rapid antigen testing, and single biomarkers like procalcitonin. All of these diagnostic tools are available. How do you decide which ones to use? And obviously, our microbiologists are a key component of making this decision because they're the ones doing this test. So do they have the skill to do these? Do they have enough of the microbiology text to dedicate to this? How difficult is the test? How large is the instrument? How expensive is the instrument? Do they have to batch the test, or are they running them 24/7? A lot of the logistics make some of these tests very difficult to implement in a hospital, but the technology is very useful. So what do we really want from a diagnostic test? What's the characteristics of that ideal test? We want it rapid. And rapid, when you look at some of the validation tests that say, 15 minutes, an hour, that may be correct if you can actually get the sample to the micro lab. So, what happens if you're in a hospital and your micro lab is 7 miles from your hospital? You're not turning that test around in any 15 minutes. So sometimes the logistics of the hospital make those rapid results not so rapid. So you really have to make sure you look at that before you start making decisions. So if you're trying to apply this to an emergency room patient who's sitting there waiting and your micro lab is, miles away, or doesn't function 24/7 and it's 2 a.m, that result isn't coming back in any 15 minutes or an hour. So those are logistics you have to work out. Specific pathogen detection and resistance markers. That's been some of the beauty of these newer tests, is now we do have resistance markers, and some are even antibiotic susceptibility. Unaffected by colonizers. We've seen the challenge with some of the rapid COVID tests where you could have one COVID gene left in your nose and you're going to forever test positive for COVID, despite the fact you're asymptomatic and don't clinically have an infection. Easy to obtain the sample. We know 30% of patients with community-acquired pneumonia can't ever produce a sputum sample, so you never have a culture to send. That's a problem. Easy to perform. Again, how complex is this for the microbiology lab? Or if you're trying to put these in outpatient centers, doctors' offices where there are no microbiologists, is it as easy as something like a rapid strep test that you don't need a microbiology degree to run the test, and inexpensive? Does the technology support an office being able to implement it without it costing $2,000 a test? So let's just look quickly at some of the pros and cons. Well, with culture, that's been the standard of care for decades. You get the specific organism and robustness to evolving strains. So if a new pathogen presents, you don't have to set up a whole new technology. Culture can accommodate that. But it's the results aren't rapid. If you can't obtain a sample, you obviously don't have any tests to run. You can pick up colonizers, and it requires a microbiologist to run that. Multiplex PCR, again, it can be rapid, assuming the microlab doesn't batch the results, or your microlab is available 24/7 and the microlab is not 7 miles from your hospital. So all of those make the definition of rapid a little variable, but they are very easy to perform, but they do have limitations. So here's one of the new rapid panels for pneumonia, and look at how far we've come in this. We have all these organisms that can be identified along with resistance markers, but this is where stewardship really has to come in. Most physicians, especially non-ID trained physicians, really don't understand these resistant genes that are reported. So that's where we work together with stewardship to help interpret the results and direct appropriate antibiotic therapy based on the resistance genes that are identified. So a really nice new contribution to our plethora of rapid diagnostic tests. So rapid antigen testing is very rapid. It's very easy to perform, but we do have limitations to it as listed here. So the pros and cons of these different tests that are available, there's strengths and weaknesses to all of them. Not one serves all of our needs. And so a challenge with stewardship is really trying to decide which technology works with our microbiology lab and which technology can we actually implement and show that it makes a difference in patient care. And so you have to understand the limitations, and we don't have that perfect test yet, but we have so many to pick from, and they all do offer something better than standard culture. So can some new technology address the current gaps and improve our use of antibiotics? We still have the dilemma of trying to distinguish, back to our patient case that we started with, is it a bacterial infection that requires an antibiotic, or is it a viral infection where we don't prescribe an antibiotic? The patient's in the ED. Can I get a test that can help me distinguish that to determine, do I give antibiotics, or will I be like that CDC study, 35% get an antibiotic, but it actually wasn't bacterial infection? So can host response technology, can that complement our current options? And so with that, I'd like to introduce our next speaker, Eran.
Welcome to IDWeek Theater, to the track titled, Is it a Bacterial or Viral Infection? Using host response technologies to decode the immune system and aid in antibiotic stewardship. Hi, I'm Eran. I'm the co-founder and CEO of Unit, co-leading it since its inception to a rapidly growing company that is a pioneer in this exciting new field called host response technologies. Let's start, first of all, by defining what are host response technologies. It's based on a simple idea. Our body's immune systems have been designed or built to tell us what's going on in our bodies. And these technologies basically listen to the immune response, often in real time, with sensors and machine learning algorithms, and translate that into simple understandings of how to better manage patients, particularly in acute infections and inflammatory disorders. Host response technologies are gaining increasing traction in recent years as measured by the volume of sheer publications coming out every month. And the reason that there's so much traction is that host response technologies have the potential to complement conventional pathogen detection tools such as cultures, PCRs, and rapid antigen tests. Building on what Professor Debbie Goff said in the earlier lecture, there's several fundamental properties that we want, that we expect from an ideal diagnostic solution in the context of acute infections. Neither culture nor multiplex PCRs or rapid antigen tests solve all of them, but they all cover some of those elements. Host response technologies are not perfect either. Let's start with what they cannot do. They cannot detect specific pathogens or resistant markers. So if you need to know if it's influenza A or influenza B, strep A versus strep B, probably host response technologies are not going to give you that level of granularity of information. However, one might argue that this is important for a subset of the patients that we're seeing, and for the majority, often it's not always accurate. What host response technologies can do is actually close the gap in some of the other elements that we'll talk about today. So it all starts with a clinical dilemma. In this case, patient presenting with suspected acute infection, is it a bacterial or viral etiology? Do we treat or not treat with antibiotics? And the paradigm behind host response is real-time quantification of the body's immune system coupled with machine learning. So we take a snapshot of the immune response through a set of sensors, and then with a layer of computational algorithms, create a barcode, if you will, telling us a picture whether the body is fighting against the bacteria or whether it's fighting against the virus. I want to start by showing you one such technology, host response technology, called MIMED-BV, that can distinguish between bacterial and viral etiologies, taking you through almost a decade of work from discovery, 4 years, then product development, 5 to 6 years, validation that took about 7 years concurrently, recently EU clearance, and now on the cusp of FDA clearance. It starts with a challenge. The immune response to bacterial and viral infections is highly complex. There's response on multiple levels, from the cellular level, proteomic level, transcriptomic level, and there's multiple elements in the system. Where do you start? Well, we started with about 4 years of discovery and initial validation of this type of technology, and we focused on soluble proteins. Why? Even though it's pretty hard to do the science, once you find what you want to measure, putting it in an easy to measure format that is rapid is more readily available. So it started with about 100,000 potential protein and protein isoforms that we screened bioinformatically, and then down selected these through a series of studies enrolling over 1,002 patients prospectively. So as far as we know, it's the largest proteomic screening ever to be conducted of the human response to acute infections, and then eventually coming up with a signature, a combination that includes 3 proteins: TRAIL, IP10, and CRP. Let's focus on TRAIL. So TRAIL is a biomarker, a protein that the body secretes to fight off particularly viral infections. It goes up in viral infections, goes down in bacterial infections. It's actually the world's first virally induced protein that's right now starting to be used as part of routine care. It's actually interesting because so far we've been obsessed with the bacterial side of the equation. Most of the biomarkers we have today go up primarily in bacterial infections, whether it's procalcitonin, bacterial infections, C-reactive protein, bacterial infections, wet blood count, bacterial infections, absolute neutrophil count, S-trem. And so we asked, well, what if we could put our hands on a virally induced protein? And this is what TRAIL is. It's an apoptotic a pathway biomarker. And what you see in this particular chart, which was published in Ovid et al. And then reproduced in Van Houten et al. In the Lancet ID, every dot is a patient, includes both children, 3-month-old baby up to a 93-year-old lady in this particular study, different types of symptoms onset, 58 different strains of pathogens. So that's each and every dot. The ones here on the left are bacterial infections, the one in the middle are viral infections. The y-axis is the levels of TREL in picogram per ml, and you can see that viral infections tend to have higher levels, but it's not a perfect biomarker. There are no perfect biomarkers. So there's an overlap here where the biomarker is less informative. Second, a protein called IP10, which is an interferon gamma-induced protein, an infectious disease marker that is elevated in response to viruses, particularly, and to lung injury. It has been receiving quite a lot of traction recently because of its pathophysiological importance in the response to COVID-19. Third, good old C-reactive protein that's been around for about 40 years. It's elevated in response to bacterial infections, but it's not a specific marker. It also goes up generally in inflammation. So again, we see that there's these levels where it's less informative. So the signature, the MimaBB signature, applies machine learning to combine these biomarkers together and produce a single numerical score, which we'll talk about. But before that, I think it's worth to demystify the machine learning behind the scenes. We tend to hear a lot about this recently, about AI and machine learning. So here is how at least the concept behind supervised learning is working. Imagine this virtual axis, trail levels, low levels bacteria, high level viral infections, indicated by the yellow and blue circles. Doesn't matter which cutoff you choose, it's not going to be perfect. But then you add another biomarker to the equation, in this case IP10, you find this nonlinear line that separates between the two, and suddenly performance increases. And then you go to 3 dimensions, and you find this hyperplane or hypersurface that separates between the cloud of bacteria and the cloud of viruses. This is what the machine learning algorithm actually does behind the scenes. It produces a score between 0 and 100. The higher the score, the higher the likelihood of a bacterial etiology. Mixed bacterial and viral co-infections will also receive a high score because from a treatment perspective, we want to prescribe antibiotics. There's also an equivocal zone where the test provides less information, but only about 8% to 10, 11% of the patients will fall in that zone. Most of the patients will fall in the extremes. The results of this study were published in PLOS, showing the accuracy, sensitivity, and specificity of roughly 92, 93% sensitivity, the accuracy by which bacterial infections were detected, and specificity, the accuracy by which viral infections were detected. But it was also met with a lot of skepticism and healthy conservatism. It's not enough to have one study like this. And so in the years to follow, there's been a series of independent blinded studies by multiple groups around the world. And actually over 20,000 patients, both prospective and real-world evidence. Here's some examples. And these were all peer-reviewed, published. What I want to do right now is to focus on some of those studies and see how they can help us close some of those gaps that we talked about in the beginning. Okay, so I want to start with how we can use host response to overcome the challenge of hard-to-obtain samples. The study on the left here, the opportunity study, was focused on 777 children, 3 months to 50 months old, with suspected lower respiratory tract infections, where obtaining the sample is particularly hard, or fever without source, where we don't really know where the infection site is. These are 2 clear examples. We're trying to go after the bug, after the pathogen is harder, because either we can't access the infection site or we don't know where it is. What we saw in this particular study, published in the Lancet ID, by a group led by Professor Louis Bon from Utrecht Medical Center, is that the performance there is roughly, again, on the order of 90% sensitivity and specificity. Observer study, it focused on adults with, again, suspected lower respiratory tract infections, where it's harder to gain access to the infection site. So using the immune response, because the immune system circulates throughout the entire body, it gives us insights into these loci that are harder to reach. Second, the MinIDWeek can identify bacterial co-infections in viral positive PCR patients. And this is a significant gap that we have today. When I have a viral positive PCR, say for influenza, it does not necessarily rule out a bacterial co-infection. So what is the action that we do? What was shown in this particular study, called the Apollo study, is that when applying the host response, MinIDWeek specifically, you can identify these bacterial co-infections. So what you see here in this study, every dot is a patient. These are all patients that are viral positive PCR from influenza, RSV, rhinoviruses. The blues are patients that had eventually a viral infection as adjudicated by an independent adjudication panel that had access to the PCRs, culture, serology, a white blood count, and a follow-up. And the orange dots are bacterial infected patients, again, adjudicated by those experts. And what you can see is that those had a bacterial co-infection, despite having a viral positive PCR, tend to have much higher scores, indicated by the orange dots being higher than the blue dots. A related question is addressing the challenge of false alarms due to colonization. So for example, if you apply multiplex PCR on the nasopharynx of a child, you will find strep pneumonia in roughly 30 to 40% of the cases. In adults, slightly lower numbers. How does that affect the performance of host response? So in this particular study, the patients were separated to those that did have carriage and those that did not have carriage of, say, strep pneumonia. And the host response was ran on these two cohorts independently, and the performance was measured in terms of raw curves. You see, the performance was by and large the same, 0.93 and 0.94, indicating that it is robust to the presence or absence of colonization. It's also robust to detection of emerging pathogens. And again, these different studies, over 60 different strains of pathogens were measured. In this particular study, the autopilot study, were focused on H1N1 swine flu, H3N2, and flu B. Again, these were classified with a high degree of accuracy. And again, we shouldn't be that surprised about this, because even though these new strains, we as a human race have to reinvent and develop new tests to capture them, the immune system has been waging this war for hundreds of millions of years. And so we get almost like a free update to basically what's going on. How does this compare to other well-established biomarkers and those that are also in research? Quite favorably, as indicated here. Here you see a comparison between the signature in blue to other biomarkers from procalcitonin to interleukin-6 to TNF-alpha. And if we zoom in just on procalcitonin, because it's the only FDA-cleared biomarker today for antimicrobial stewardship, the BV signature performs favorably, irrespective of the different cutoffs. Here you see PCT on a cutoff of 0.1, 0.25, 0.5, and 1, which are well acceptable. And even though you can play with the different sensitivity and specificity, the signature can hold both of them pretty high levels. The next question is, well, why does it work? Why can this host response signature combination of multiple biomarkers outperform single biomarkers? And I want to focus today on two reasons. The first one, complementary temporal dynamics, and the second is biological pathways. Single biomarkers have unique temporal dynamics with specific blind spots. Take, for example, C-reactive protein. It's relatively okay after 48 hours, but it has a blind spot in the first 48 hours. I want to show here the data. So every dot here is a patient with suspected acute infection. The blues are viral infections, the reds are bacterial infections, and the solid line is the average across the population across different time from symptoms onset measured in days. And again, what we can see here, the optimal window is after 48 hours, where you get a good differentiation. If you move and look at trail, first of all, it flips. High levels are indicative of viral infections, and you can see that actually at time since symptoms onset, it is already differentially expressed. But performance starts to degrade as we move into later at that disease course. And same goes for IP10, pretty good at the early stage, less informative at later stages of the disease. When you combine all of them together with a machine learning algorithm, you actually see that the optimal window becomes irrespective or robust the time from symptoms onset, because you use the best of all worlds for each one of the biomarkers across the different times. The second reason that it outperforms single biomarkers is that it relies on complementary biological pathways, and I want to give you just one example. So adenoviruses are known to cause elevation of bacterial host biomarkers, leading to poor specificity. For example, CRP is going to be overly elevated in adenoviruses. Procalcitonin, hallmark of bacterial infections, elevated. Absolute neutrophil count, elevated. White blood count, elevated. And so, even if you try to combine them in your mind together, adding several mistakes will still lead to a mistake. By looking at complementary pathways, and not only look at the bacterial side of the equation, but also viral side of the equation, for example, trail and IP10, the signature is able to salvage and save some of these patients that would otherwise create false positives, again, by the mere fact that it's complementary pathways. And that's what you're seeing here. Next challenge is, well, how do you measure it in an easy format that fits the workflow? One of the challenges is that some of the proteins we're measuring are picograms, some are nanogram, and some are microgram per ml. We have an internal joke that measuring picogram per ml is equivalent of covering a soccer field with 2 kilometers of M&Ms, hiding the random number between a 0 and 1,000 Skittles. You have to go and count the Skittles. You have 15 minutes, go. It's pretty hard. You can usually do this only on large automated immunoassay machines. What we've done here, after almost 6-7 years of work, we've been able, together with partners and with funding of the US Department of Defense and the European Commission, to develop this small form factor device. You put the sample in the cartridge, in this orange slot. You plug it inside, press the start button, and that's it. 15 minutes, and you get the results. Both single biomarkers and the score itself, in this case, scored 1, high likelihood of a viral infection. So just to give you a little bit of a recap on this particular platform, can produce high analytical performance, measure multiple proteins, results within minutes, 15 minutes from serum sample to answer. Obviously, the overall turnaround time is larger because you need the pre-processing, post-processing, and what have you. There's also, right now, additional developments that are done to move this into whole blood and capillary blood. It's easy to use, and it can measure actually any host proteins, so you can evolve this to develop additional tests on top of the same platform. So when you take all of this together, what does this mean? If you want to estimate the potential of the MIMID BV to impact an antibiotics overuse, in this particular study, the Apollo study, it was estimated that the MIMID BV can reduce overuse by more than 2-fold. And how is this actually measured? So for each one of the patients, an extra panel adjudication process was run to determine what the underlying etiology was. And about 35% of the cases that had a viral etiology received antibiotics. If one would have used the technology, the test, you could potentially reduce that to 14%, which is 2.6-fold decrease. So to summarize, post-response technologies have the potential to close gaps of conventional pathogen detection tools. First of all, what it cannot do. It cannot detect specific pathogens. So if you need to know if it's influenza A versus influenza B, strep A versus strep B, you need to use more conventional tests from cultures, multiplex PCRs, and rapid antigen tests. Is that information important? Yes, for some patients. Often for the majority of the patients, it is less actionable. Where you do want to use host response is to try to solve or close the gaps in some of these other elements. You can get the results extremely fast, within minutes, particularly if you're focusing on proteins, you can get it within 10-15 minutes. It works on inaccessible infections, pneumonia, suspected lower respiratory tract infections in general, fever without source, because the immune system circulates throughout the entire body. It is unaffected by colonization, and importantly, it can detect bacterial co-infections in viral positive PCRs. So it really supplements what we have today. Pretty easy to perform, and it is robust to evolving strains of bacteria and viruses. I want to end with the same case study that Professor Goff showed in the previous presentation. So we start with this 50-year-old female that has a fever for 5 days, non-productive cough, decreased breath sounds bilaterally on physical exam. The laboratory findings are COVID-19 PCR negative, slightly elevated white blood cell count, and a CRP of 36. The chest X-ray is bilateral infiltrates, and blood culture was sent. Now, in this particular study conducted in Israel, every treating physician had to complete a questionnaire upon patient encounter. So what that physician felt is that she suspects a viral pneumonia, but cannot exclude a bacterial pneumonia or a bacterial co-infection. So she considered treating with antibiotics. Then she received the score. The score was 1, high likelihood of a viral infection. If you zoom in on the single biomarkers, CRP was 36, elevated, but it's borderline, so it's less informative. IP10 of 654 indicates high likelihood of an infectious process, but still doesn't separate between bacterial and viral etiologies. The trail of 207 is highly elevated, indicating a viral process, and thereby influencing the score to be very low. As a result of this, the physician decided not to prescribe antibiotics. Next day, follow-up phone call, fever down, cough was improving, and the negative blood culture eventually came out. So this is an example of a seemingly simple dilemma that we encounter so often, almost on a daily basis. This type of a technology can help us bridge the gap. Thank you very much, and happy to take questions.
Dr. Goff, Dr. Eden, thank you for your presentation. I'm sure there'll be many questions coming in. Already I see some. The first question is for Dr. Goff. How do you see stewardship implementing such a technology in their hospital system?
It's a great question. And when I first learned about this technology, I'm always looking for something new to help us make that distinction. And so when I would roll out a new test, I like to target and focus a specific group. And I would see the highest value in our emergency room department. That's where they're trying to, they see the volume of these patients and they don't have any ability currently to make this distinction of bacterial or viral. And as the CDC study showed us, we often prescribe antibiotics. So I would partner my microbiologist with our ED physicians to look at a strategy to implement it in the ED. And that's where I personally would roll it out first.
Thank you for that. Next question would be for Dr. Eden. How did you come up with a way to evaluate the performance in the absence of a gold standard?
Yeah, that's a great question. So one of the big challenges that you have when developing this type of technology is, well, what's the performance? What do you compare yourself, again, in the absence of a perfect reference standard? We used a dual approach. We collected all the possible information you can have on each patient from cultures, PCRs, rapid antigen tests, and what have you. And one reference standard that we used was microbiological confirmation. Advantages: in many of those cases, you have a high degree of certainty what the infection is. For example, a urinary tract infection, positive detection, plus other indicators can give you a pretty good sense that you're dealing here with a bacterial infection. The advantage is, again, you have high quality. The disadvantage is that you're only going to have microbiological confirmation in a small portion of the patients. Someone might, I would say, recently argue that you're cherry picking the easier to diagnose patients. So on top of that, we also added a layer using the expert panel adjudication process. The other part of the equation is to use an expert panel adjudicators, where you basically put the experts in separate rooms to avoid charismatic personality bias. And then each one of them puts a label: bacterial, viral, mixed infection, and a non-infectious. And based on this consensus process, you actually come up also with a reference standard. The second type of reference standard is arguably suboptimal, not perfect, because we don't make perfect diagnosis, but arguably this can give you a more conservative estimate of the performance. And if the two, the microbiological confirmed and expert panel adjudication performance tend to converge, you know that reality is somewhere in between. So this is the framework that we and others have used in a series of publications that today is starting to be accepted as the way to actually drive these type of assessment performance on tests.
Thank you for that. Dr. Goff, although you kind of alluded to some of these answers while you were presenting, but specifically, which clinical indication do you think host response technology can have a bigger impact on?
Well, in my opinion, where I would first start, if I was starting in the ED, would be respiratory tract infections, upper or lower. You know, those are the patients, whether they're adults or pediatric, that you can't always get a sample. I mean, you can't induce sputum if they're not producing, or you get a sputum sample that is actually just spit, and so it becomes worthless. And so, you know, when you look at this technology, that's really what caught my attention, is it's not culture dependent. So it's so different and novel compared to everything else we do that I see that as a very big advantage. And in those patients, we frequently are not able to get samples. So I think that's where I would start.
Thank you for that. Next question is for Dr. Eden. How can the test be used to complement multiple PCRs? You alluded to that a little bit, but can you expand on that answer? And also Dr. Goff.
Absolutely. Dr. Goff, do you wanna take the question first?
Well, sure. I think, again, in my opinion, it's not culture based. And so you have the ability, it's just such a different technology that I think that to me is the biggest advantage of comparing it to other tests. It's complementary.
And I think building on what Professor Debbie Goff just mentioned, if you take, for example, PCR, often when you have a positive detection of a virus, it does not rule out a bacterial co-infection. Rhinoviruses, influenza tend to be very friendly viruses. Often we have a bacterial co-infection that sits on top of the virus. So if you run this host response technology together with a PCR, it can actually identify bacterial co-infections on viral PCR positive patients, thereby, again, giving you information that's actionable. So that's, I believe, one area where using the two in tandem or in combination can really give you an added value.
Thank you for that. Next question for Dr. Goff. How would you use such a host response technology in your medical practice?
So again, if I was to start this technology in my ED, you know, what I liked about it is it's a small instrument. It's not the size of a refrigerator. And looking at the ease of doing the test, it's not microbiology dependent, meaning I don't have to have a microbiologist in the emergency department to run this test. And that's just not reality. That's never going to happen. So the fact that it looks like it will be CLIA waived, again, that's not approved yet in the US, but the ease of the instrument, to have someone in the ED dedicated to run it, to me is a really novel idea and very easy, because now the turnaround time is not going to be dependent upon someone delivering the sample to the microlab, which is a big barrier for time, especially if your microlab is not on site and it's off site, which is our experience. Our microlab is not actually in our hospital. It's further away. So those to me are ways that I think this technology can complement what we're already using and actually deliver results that allow the ED physicians to make an actionable event and see the result and say, we don't need to prescribe antibiotics. So I think that would be the impact of this technology in my setting.
Perfect. Thank you for that. Next question is for Dr. Eden. How does early co-infection play a role in your scoring system?
Yeah, so I think early infections, and specifically early core infections, is a critical point because we want often to, it's all about actionability. We want to be able to act early enough. And one of the points I was trying to make in the slides is that different biomarkers have different blind spots. For example, some of the conventional biomarkers we're using today, C-reactive protein takes about 48 hours to reach maximal levels. So we have a blind spot in the first 48 hours to detect bacterial co-infections. Procalcitonin is faster, 12, 18 hours, but still, especially in the peds population, they tend to come quite early. You have a blind spot. By using a host response that has biomarkers with different dynamics, such as trail, that is already differentially expressed at the time of symptoms onset, you actually are able to identify infections and specifically co-infections in a very early time of infection, thereby allowing you to treat when it actually matters, at the actual encounter, and when the infection actually didn't go out of control.
And for that, thank you, Dr. Eden. It actually raises another question that you both can answer. The value of the actionable diagnostic testing, considering that practicing clinician kind of have a mindset. How would you bring this in front of them, and what value would you present to them that could change mindset, considering that in medicine, nothing happens overnight? So Dr. Goff, you first.
Oh, yes. So that's a tough one. I think the first step is, are we happy with the tools we have currently? So I always like to get the audience that I'm speaking to buy in and basically tell me before I say anything, no, we're not happy with the way everything works right now, and we need something new would be welcome. And then I open with what that new test might do, what it might provide, and the value it would provide to our patients. And so to me, that's the approach I would take. Are we happy with all the diagnostic tools you have in the ED right now to determine bacterial or viral infections? And then have them answer. And I'm pretty confident the answer would be no. Okay, so here's a new technology. It's going to complement what we currently do. And then together you really develop a strategy of the workflow. So here's what we've learned so far. So we're going to do this test as you're trying to make that decision. What are the diagnostic signs and symptoms that patient must be presenting to qualify to have this test done? What's your clinical dilemma? Then we have the test, and the test is going to be done right here in the ED. And then we're going to turn around the results, and then we're going to together make a decision based on these results. We're still, if we can get us a culture sample, whether it be respiratory or blood, we're still going to send that, because if they get admitted, I want to still know the organism, because we have so much drug resistance. You do need to know that. So we're not going to stop doing what we've traditionally done, but we're going to implement this new technology. And I would personally set it up as a study. I want to see, does it actually impact decision making? And we know with some other tests that have tried to distinguish bacterial or viral infections, but they're different technology than what was just described. It wasn't able to make a difference because people just were so hesitant to believe the results. And so you really need someone to hold the hands of the clinician making the decision to say, no, this really is definitive, and we're not, or we are going to start antibiotics. So, to me, it's always a team-based approach. And when it's new, you don't have 100% of the answers. But if we're going to study it together and give them feedback in real time, that's really reassuring. So I want to see it make a difference and be able to track that difference. And that would be my strategy.
Perfect. Thank you. Dr. Eden?
Sure. So I think when you take such a novel technology that can potentially be used so broadly, it's hard to really think how to use this really practically. So I think one of the approaches that we've been developing with our collaborators, frankly, around the world, is to start with very focused clinical scenarios. Yes, you can use this across multiple infections, but let's not start there. Let's start with respiratory tract infections, and even within respiratory tract infections, maybe with suspected lower respiratory tract infections, where we know that we have a pain point. So, for example, let's talk about suspected lower respiratory tract infections in children. As an example, hard to get the sample, so it's harder to apply a multiplex PCR, number one. Number two, children tend to have a very vibrant micro flora or natural flora. So even if I am detecting something, rhinovirus, what does that mean? We have about 35% carriage rate. Identified pneumococcus, what does that mean clinically? It's not actionable. So there is a real blind spot there for the current technologies. It's painful to make a false positive. It's painful to do a false negative. Much more painful. So you go for those indications where there's a real clinical need. The technologies that we have today are inherently, that's where they have the bigger gaps. And so you start there, because I think once you show the value in those indications, people tend to have more belief that they can actually expand this in other indications. And one of the things that we've done as part of the early access program in Israel, where this is actually already cleared, actually put it in the hands of clinicians in a very focused environment, such as the indication, such as the one I just told you. And what you see, they do see the value. And once they see the value there, then they're ready to start experimenting and seeing how they can actually expand to that. And again, building on what Professor Goff said, obviously they're also tracking and monitoring this, so you can actually prove from a clinical utility, you can actually prove the benefit. So start small or narrow and focused, and then expand. That is the approach that I think we've seen this as being very effective.
Thank you for that. Dr. Goff, knowing that since 2015, inpatient stewardship has shown so much value for physicians, and there are actually trackable, measurable environment being set up for that. I have heard over the next 3 years, outpatient stewardship is becoming very important. How do you assume we look into something like that? Because now the impact on patient population would be much greater, but at the same time, our ability to impact them becomes less because we lose a little bit of control over what happens in the outpatient population.
Right. Well, that is a great dilemma for stewardship, is now expanding our bandwidth into outpatient stewardship. So it's actually mandated in Joint Commission accredited outpatient settings. So like at Ohio State University, our clinics are Joint Commission accredited. So outpatient stewardship is already required. Most outpatient settings, surgical suites and that, are not Joint Commission accredited, so not all are required. But you're absolutely right. It's just a matter of time where outpatient stewardship will be mandated across the board, because we are running out of effective antibiotics. And I'm actually in the process of doing a very large dental outpatient stewardship study right now, and there's a lot of work to be done. But when I look at this, you know, part of the challenge in going into the outpatient setting, we know the CDC has already done studies. More inappropriate antibiotic use, the tonnage, is in the outpatient setting, not the inpatient setting. And so that's really where stewardship needs to be spending their time, but it's so much harder because the clinics are spread out. You know, you only have a handful of physicians versus in the hospital, I have thousands I'm working with at one time. So it's a harder task, but when you look at the value of this, imagine if this technology, this platform, which is small and able to fit into a private practice office, the value to patients, because if you could bring your child to the doctor's office and, you know, they can't go to daycare because their nose is dripping and they might have something infectious, and you could quickly determine bacterial or viral, or even an adult who, you know, you don't want to return to work if you're sick and contagious, and do I need an antibiotic or not? The ability to know that definitively is really powerful and meets the stewardship initiatives, because the first thing is to do no harm, and antibiotics do create harm. 1 in 5 will have a serious adverse event from an antibiotic. So if the antibiotic is unnecessary, as the CDC has told us, over 30% in the outpatient setting are unnecessary because we can't make this distinction. A tool like this, a platform like this, solves that problem. So I see there's a huge need. Now we have to prove it actually does allow clinicians to make that definitive call, viral or bacterial, antibiotic or no antibiotic.
Thank you for that. You brought up a great point, and one of the quotes that always sits very warm with me is from Sir William Osler, that said, "The person who takes medicine must recover twice, once from the disease and once from the medicine."
Yeah.
So antibiotics certainly has played a huge role in that notion. How would you bring the idea of outpatient stewardship to clinicians who, to your point, are not centralized?
Right.
And how would you think a company like MeMed would present this to clinicians? I mean, everybody's aware of AMR, but
wait, let me stop you right there. That is not an accurate statement.
Correct.
We'd like to believe everyone's aware of it, but actually everybody is not. Go on.
Well, I make a correction. The population of clinicians I have dealt with,
yes,
because of my area of expertise.
Yes.
But you're absolutely right. So how would you present that? Because it becomes the notion of, well, it's not my problem, it's the general problem. But we know few tends to become more, and more becomes way too many. And that's how we end up where we are.
Right. So doing outpatient stewardship is far more difficult than inpatient antibiotic stewardship. And I can say that because I've been doing it now for 1 year with dentists. And we actually surveyed clinics not affiliated with Ohio State. I wanted to look at those physician private practice clinics. The amount of time and effort it takes to meet with them is enormous. So it's a huge problem, and it's very hard to engage people in a topic that they don't think is relevant to their practice. So actually in our study in working with private practice dentists, the term dental antibiotic stewardship was not even known. They didn't even know what it was. They're like, what is it? Therefore, how are you going to engage them in a conversation in a topic that they see no relevance because they don't even know what it is? So when you talk to private practice physicians, they're running, they're obviously treating patients, and but they're also running a business. So when you're coming at them with a new idea, every minute they're spending with me, they're not seeing patients, which means there's no revenue coming in. So it's a very different model, and you have to really respect that and find what is it that will motivate them to actually just even give you the time to have the first conversation. When you can show and state with conviction, I've been doing this a long time in the hospital setting, I can absolutely tell you this will help your patients. So I would simply, again, just kind of the same way I'd approach working with ED physicians. Are you happy with how you see your patients that come to you with respiratory tract infections, and you're trying to decide, is it viral or bacterial? Do I need to prescribe an antibiotic or not? Are you happy with your current approach to all those patients? And there isn't anyone that's going to say yes, because we can't make that distinction. And that's why so many antibiotics are prescribed unnecessarily. So that would be the way I would approach them. But outpatient stewardship is very time intensive on the steward's part. And it's a very different strategy that you really have to think through. So we've learned a lot in our dental stewardship initiative. It's all been positive. One thing I will say, they are so appreciative to have someone give them guidance on an issue that they really didn't even know existed. But now that they know, they are very easy to work with. So it's been really rewarding, but it is a very different approach.
Thank you for that. We have about 3 minutes or so. So there is one last question for Dr. Eran. What makes your expert panel in your study any different than the docs in my ED and urgent care?
Okay, so there's several elements that were baked into the study to try to ensure that the reference standard is obviously not perfect, but it's as good as we can. The first one, every participant as part of the expert panel adjudication process had to have a certain amount of training and years of experience in the relevant field. So for example, pediatrics, infectious disease, what have you, number one. Number two, they had the benefit of tests that you usually don't have for every patient. So for every patient, they had the culture, they had the PCR, a multiplex PCR, a nasopharyngeal sample, stool sample, what have you. They have serology, they have the chemistry, they have the well blood count, they had the chest, et cetera, et cetera. So you provide them a lot of information that's not always readily available. Third, they had the benefit of hindsight. So sometimes it's really hard to figure out what the patient has in real time, but after monitoring the disease course, it's easier to actually figure out what happens. And lastly, you have here a panel of several experts that if you put in separate rooms, to avoid charismatic personality bias, this is something that it's a bias that's been recorded again and again in multiple studies. So you do that, now you basically run a process where you get a majority or consensus. If you have 3 independent experts, they have all this information, plus the benefit of hindsight, that all get to the same result. It's not perfect, but it's probably the best that we can in 21st century medicine.
Perfect. Thank you for that answer. Well, with time in mind, I want to thank you, Dr. Debbie Goff, for her presentation and participation on our panel. Also, thank you, Dr. Eran, for your presentation and answering all the questions. And everyone who participated in this presentation, I'd like to thank you all. If we were not able to answer your questions, please feel free to reach out to us at NEMED. I forgot to introduce myself. I'm Dr. Mo Abuzari. I'm a Senior Medical Science Liaison with NEMED, and I appreciate your time today, everyone. Have a wonderful rest of the week and other IDWeek presentations. Thank you.
Thank you very much.
Thank you.